here we go.
All right, I'm going to share screen. Do you see the correct screen?
Yep.
Oh, so annoying. All right, well, anyway. Should I go ahead?
Go ahead.
Oh, wait a minute. Hang on. Did that make it go away?
Yes, yes. What did you do?
There's a button at the, apparently it's on my PowerPoint for some reason that was doing it. So I made the screen bigger, so it's like, it's off the screen now. I think it's still doing it, just off the screen now. Okay.
Okay,
Yay.
awesome.
All right. Good afternoon, everyone. Good afternoon. My name is Deb Stein. I'm very sorry I can't be there in person with you all, but I am really, really pleased to be here to present the results of the neurotrauma panel for the National Trauma Research Action Plan. This is our visual abstract that we published in the Journal of Trauma and Acute Care Surgery. And obviously, similar to the other groups, we had an interdisciplinary group of experts in neurotrauma care and research, work to identify gaps in knowledge, generate research questions, and prioritize those questions using this consensus-driven Delphi survey that you've heard about. And basically, we were able to come up with 675 research questions, 364 of which reached consensus at a level of 60% or above. 15.4% were high priority, 83% medium priority, and only 1.4% low priority. I will say that for the purposes of our group, we did kind of divide up those research questions into three groups, one being severe traumatic brain injury, one being mild traumatic brain injury, and the other one being spinal cord injury, just because those questions are so different and so diverse, and it was really hard to lump those all together. Oh, excuse me. Our group was compared, you can see the composition of our group, the neurotrauma panel makeup. 33% were neurosurgeons, 30% intensivists, and you can see down the list there. Most of us were in hospital-based practice. Some of us were in trauma systems and informatics, and a couple of long-term care providers as well, and a few injury preventionalists. And basically, our top 5 questions were, not surprisingly, I don't think to anybody who's lived in this world for any period of time, is going to be, does autoregulation inform management improve outcome in severe traumatic brain injury? Does a personalized approach to TBI care with respect to ICP targets alter outcomes? Does continuous EEG monitoring improve outcome after severe TBI? Are there sequences in MRI that would be more effective for prognostication than what we currently use or are currently routinely used? And then are there TBI-specific biomarkers that can be used to generate an overall what we would call biosignature or subcategorization of individuals with similar TBI pathologies to help guide our initial imaging, our examinations, serum biomarkers, et cetera. And I'll go into a little bit more on detail on each of these. And like the other panels, we took our questions and we did divide them up by the NTRAP's taxonomy. And you can see that the most infrequent types of taxonomic concepts that were interventional or comparative effectiveness trials, that was most frequently assigned to our research, to our panel's research questions that reached consensus. Outcomes research was a distant second to that. Our interventions that were most frequently assigned included patient monitoring, pharmaceutical therapies, and imaging. And what was really interesting, but not surprisingly to those of us who do this work for a living, the outcome of interest was really functional in nature. In fact, mortality as an outcome measure was not recommended in any question, which really highlights the concept of that traumatic brain injury and spinal cord injury, but particularly traumatic brain injury, is really much more than just lived or died. It's very much a matter of how did the patient ultimately do from a functional outcome perspective. And I think that that's a really important thing to highlight. When we looked at severe traumatic brain injury, again, dividing it up into those 3 categories, severe, mild, and spinal cord, the research questions about personalized and optimal monitoring strategies really dominated our entire list. The things that were felt to be extremely important investigations for further research would be defining optimal cerebral perfusion pressure and pressure reactivity indices, evaluating how to optimize these cerebral perfusion and pressure reactivity, and the role of ICP targets based on individual patient characteristics, age, or lesion size. This theme of specificity in monitoring came up a couple more times with respect to high priority prioritization of biosignatures, the role of multimodal monitoring, as well as the ability to better prognosticate, particularly with either biomarkers or with advanced imaging such as MRI. Additionally, a kind of a separate theme that emerged was this concept of some geriatric specific questions, particularly around ICP monitoring, but also other other questions around geriatric or older adult specific questions that people would like to ask, given that many of our current TBI research really doesn't focus on those individuals, and that disease tends to be a very different disease than it is in young people. With respect to mild traumatic brain injury, the NTRAP taxonomy assigned categories for type of research and outcome were similar to that for the whole panel, but phases of care and interventions were prioritized a little bit differently, not surprisingly, given the difference in mild versus severe traumatic brain injury. The most common phases of care addressed were for our research questions were in the pre-hospital environment as well as the emergency department. And the interventions that were most commonly highlighted were imaging, physical examination, laboratory measures, and patient monitoring for most of our high percentage of high priority questions. Spinal cord injury was a little bit different. The research questions primarily focused on operative interventions, technological solutions. A lot on rehabilitation was really highly prioritized. And about 50% of the patient monitoring research questions received a high priority assessment. And what was really interesting about this group of questions, research questions, remarkable consistency with respect to the highest priority spinal cord injury research questions. So we really kind of came into focus on that and was able to consolidate around a bunch of really important concepts. This is just graphically demonstrating a lot of what I've been talking about. Clearly, interventional clinical trials and comparative effectiveness really dominated our taxonomy. And you can see here for traumatic brain injury in in-hospital critical care setting, which was obviously different than it would be for mild traumatic brain injury, since those patients don't ever make it to the critical care setting. So we talk about what the biggest gaps are, what are the most important questions to answer. I think it kind of summarized for severe traumatic brain injury, this concept of individualization of monitoring and biosignatures really was super high priority amongst the group, as well as this issue of how do we manage patients with severe traumatic brain injury later in life or our older adult patient populations. With respect to mild traumatic brain injury, it's really the questions were really around detection and imaging. And then for spinal cord injury, kind of a very different focus was really on surgical management as well as high quality rehabilitation. Lastly, some ideas for secondary analyses within the panel data, and I will tell you that some of this work is ongoing now. One is to figure out how to prioritize traumatic brain injury and spinal cord injury across the different domains from all the NTRAP groups. So how does that kind of dovetail in with what the critical care group was doing or what the prevention group was doing, and where can we find areas of common synergy? The other thing is to really do a much more detailed subgroup analyses of severe traumatic brain injury, mild traumatic brain injury, and spinal cord injury, rather than lumping together, but really do some splitting there to see if there's some signal in there that can really help guide our research efforts going forward. I'll close there. Again, I thank you for the opportunity to be here. Very sorry I can't be here in person, but if anybody would like to reach out to me, please feel free to contact me. Happy to answer questions or collaborate on anybody who has ideas about how to utilize this data to better do better research and ultimately prioritize better outcomes. So thank you. All right.
All right, let me